thinking about the ways we pay for care, the way we measure quality of care, and then how we might want to improve the value of healthcare. The results from our work suggest that specialists respond to financial incentives differently, in some ways, differently than theory would predict. And that there are different specialists, there are a lot of different specialists, as we know, and they're treating different patients, and they might be responding differently if a patient has an acute need or a chronic need. They're also going to be responding differently based on where they work, a hospital or an office. And then they're responding differently for different types of procedures, elective versus urgent care. And then a sort of overall takeaway point that I'm sure Glenn will be happy to hear is that I think in my assessment of everything that we've done, I think just having like one single payment model, like we have in Alberta, you either have like, in most cases, you either have fee-for-service or a salary type model. That just having this single model that is applied to all specialist physicians is probably not the best way to go, and then we might want to look at models that include different payment models in a blended model, and think about how we're designing them to target specific specialists or specific procedures those specialists are delivering. So, just a brief intro again about my postdoc and what I was hoping to get out of it. So, as most postdocs would hope, I think I was hoping to have this training, additional training, and develop my research program in hopes of getting an assistant professor position. And that was really supported by IIT and NOAHE, because right after I started, I got funding from them to do my postdoctoral fellowship, so that was great. So that's why they're supporting all of my work. And I also, luckily, he joined us. Also, I did not add Braden standing here supporting all of this, but he also has supported me a lot personally, professionally, and I really appreciate that. But so again, just a little bit more about like why I was doing what I was doing as postdoc and why. We saw we've seen increasing healthcare costs in Canada, a lot of it due to increases in chronic disease prevalence and care healthcare costs. And again, there's a lot of safe and cost-effective interventions that are available, but a lot of patients aren't getting them. And some work that our colleague Dave Campbell did identified that physician compensation is a barrier to improving the quality of chronic disease care. So that's where we started all of this. So some background on theory of physician payment to get us on the same page. So physician payment is considered like a financial incentive, and the economic model underlying all of this is called principal agent theory. So we can think, this could apply to a lot of different other fields, but in what we're talking about in healthcare, the physician is the agent, and then some sort of healthcare payer is the principal, and the payment is trying to get the agent to do what the principal wants them to do, essentially. So ideally, you'd want to like have the payment model be set up so that you would get the outcomes you would get from the physicians would be aligned with the goals of the healthcare system specifically. And so some of the outcomes that we were interested in looking at are the patients that physicians are choosing to see, the quality of care being delivered, the patient's clinical outcomes, what you would hope it would improve if the quality improves, utilization of care, access to care, healthcare costs, and patient and physician satisfaction. So if we think about all these different payment models, we can think about them on this continuum, from the least aggregated to the most aggregated. So the units of aggregation that we can think about are that going from across the continuum are procedure, episode, patient, and time. So the payment models that align with these different types of aggregation are if you're paying for a procedure, that's called fee for service. And then if you're paying for an episode of care, in the US, there's US Medicare diagnostic related groups. In Canada, we have case mix groups, or in the US, there's also been bundle payments that we pay for, and the way the US has done it tends to pay for care like in a hospital and then following up in some sort of rehab type facility. And I think activity-based funding would also fit in here, which has been experimented with in Canada too. If you're paying by patient, it's called capitation. If you're paying by time, we call it a salary. So there's other ways that if you're paying by time, not like the most, I think, common way to think about salary is you're paid for a year of a job. So in physicians, it can look a little differently. You might call it sessional payment, or there's some like in the emergency department, you can be paid per day. So there are some different variations of this as well. Okay, so these different payment models have different incentives. The incentives I have up on the screen are focusing on utilization, but we can think about incentives in other areas for other healthcare outcomes too. So the incentive that comes along with fee-for-service is to deliver a higher volume of services because you're being paid for each service you're delivering. Then for an episode, there can also be an incentive to do more episodes because you get paid per episode you're doing. But then within that episode, to try to save money, you could possibly undersupply services. So this also would vary by like the type of care. Like, so if you're having an episode for paying for obstetrics care, which is relevant in my life right now, you can't probably increase those number of episodes because there's the same number. Like a doctor can't change the number of women who are pregnant. But like say it's about paying for knee surgery, then you could maybe increase the number of knee surgeries that you're doing more easily. So capitation, there's an incentive to, and salary both, there's an incentive to undersupply services because you're not going to make more money for doing more. You make more money for doing less essentially because you're not, the amount of money you're getting isn't really changing for what which specific healthcare services you're delivering. And then blended models, which is another thing we can think about, like could mix different good or bad elements of these different payment models. Ideally, you want to mix the good ones to sort of maximize the advantage of what the incentives are doing to drive the physician behavior. So, I mean, we could also think about how this impacts coordination of care. Like fee-for-service, physicians would tend to want to keep their own patients because they would make money on doing care for those patients and wouldn't necessarily want to refer them to somebody else. And that's the point that you might want to, we think there might be differences between GPs and specialists, because the specialists, like, they really might need to refer a patient to somewhere else where they don't have the knowledge of that healthcare problem.
Are you taking questions now? Or?
Sure, I'm sure, yes. And from the room, yes. I don't know if online we can't see the box of questions, so I cannot take those until the end. So I'll let you.
I mean, this isn't very different for a lot of areas of work. So a teacher, you could pay them by the kid's grade. You could, pay lots of other professionals in these ways, but we don't. Is there a reason that we think that it should be done for physicians and not other professionals that might even have the same similar incentives and stuff?
Like why, like alternative kinds of payment models are relevant for physicians? Well, I think my most like econ theory answer to that is that like healthcare has a lot more risk involved, and sort of the economics of it are different because of that. And I don't know if that necessarily means we would have to consider these other models, but like I think like addressing the sort of like, I mean, it's challenging teaching a child, so it's also challenging like determining what care a patient might need, when, and why. So is that more specialized in healthcare than education? physicians do tend to have more training, more specialized training than like an elementary school teacher, for example. So, and we might want to. I don't know, it's an interesting question. Do you have some? Oh, Deborah.
Yeah, thanks. Could you comment on where would it fit in your physician payment model stream, I guess? The idea that physicians would be paid based on outcome-based measures. Where does that fit?
I don't know if that's sort of in the same continuum. I think that might be different because that's not aggregating by like a unit of time. I think it would be a different thing.
Well, some of those episode-based payment models are paying based on the outcomes the physician achieves.
Yeah. A lot of the episode-based payments like include both the cost and quality type results.
Also, blended cap would have pay for performance elements weaved into it. So,
Yeah, that's a good
for
point. Thanks,
example,
Lynn.
okay,
Maybe, like in the blended, I mean, I guess the idea of only paying a physician for outcomes, I think seems pretty challenging. So if you were paying them like a salary plus a bonus for reaching some certain patient targets, then that would be the blended model. Okay, so some examples of these different models that I'm going to be talking about today. A fee-for-service, a strategy of like paying through fee-for-service and then increasing a fee and seeing what happens. An example of that is paying nephrologists for peritoneal dialysis in Alberta. A bundle payment example that I referred to was paying for perinatal care in Arkansas. An example of a capitated payment was in U.S. Medicare, but just the study done in Missouri, where they switched ophthalmologists from being paid from fee-for-service to capitation, which resulted in reducing elective cataract surgeries. An example salary model is like what a lot of my work is focused on, which is the academic alternative relationship plan in Alberta, which is now called the Academic Medicine and Health Services Program. And then a blended model example is in U.S. Medicare. A lot of a number of studies I'm going to be talking about looked at this model where they had been paying physicians capitated rate and then they switched to blended capitation that had capitation plus fee for service that was designed to increase the number of visits that patients were going to see their physicians per month. And it did do that. Okay, any more questions on this? Okay, so a first step in trying to understand what is the evidence for specialist payment specifically, like versus just physician payment research in general, was to synthesize the evidence. And we did a systematic review, and the reason I'm specifying Canada and the U.S. is because the studies we found were only from Canada and the U.S. So this paper is, as I said, a systematic review about specialist payment, and it's currently in a revised and resubmit stage. So it's crumpled a piece of paper is about how I feel about it right now. And so a lot of the research on physician payment and the theory that I talked about is general to all physicians. There's not like a theory paper on specialist physicians and a theory paper on primary care physicians. So, and then there is research in this area, but a lot of it, again, is about just primary care physicians. So a lot of our motivation to do the study was to understand what the association of specialist physician payment specifically was with a range of outcomes: healthcare quality, clinical outcomes, utilization, access, and cost, and patient and physician satisfaction. And then we were also wondering, do specialists respond to these incentives differently than we would expect based on the theory? So we conducted this systematic review. We searched Medline and Base and a number of other databases from their inception through October 2018 looked at the major, there's a lot of different search terms we used, but like the groups of them were like, first we were looking for specialist positions, then we were looking for payment models, and then we looked for study designs, and we combined those terms in different ways to try to find relevant papers. We ended up identifying over 13,000 abstracts and screened those for their relevance, and that ended up with 390 full text articles that we assessed. And then of all of that, ended up with only 11 studies that we included in our qualitative analysis. So just some brief, I'm not going to go into like super depth on these different studies, but just some like key outcomes from each of them. Again, I said they're all from the United States and Canada. There's a broad range of outcomes that they looked at and how they defined even, similar outcomes between them. And there was like a huge range of like the number of physicians and number of physicians and patients involved. So let's start in Canada, since that's where we are. So a pretty recent emergency department payment reform happened. It was mostly just in Vancouver area, and so they switched, the physicians were paid a salary type model, and then they switched to be paying them fee for service. And another thing I should say actually more broadly is, so all of these studies are either a controlled before and after study or a interrupted time series analysis. And in the interrupted time series analyses, most of them also have a comparison group. So we were looking for like high quality, rigorous research. So anyway, back to the emergency department reform. So when they switched from like salary to fee for service, the goal of the model was really actually to retain staff, but they the study really looked at more like access and efficiency of emergency department care, and they found that there wasn't an immediate improvement of people being seen. I think like 10. Yeah, they reduced wait time for being seen in ED by 10 minutes initially, but then that was not sustained over time, and then they didn't change the rate of people being seen before they left initially, but then over time there was a 0.05% improvement. Some statistical significance, but that's not necessarily like clinically or meaningful to patients. Then in anesthesiology reform that happened in Ontario, what they did was switch from fee for service to a salary model, and there was absolutely no effect on the care that they measured all utilization outcomes. There was no difference in what the control group and the intervention group did. And then lastly, in Canada, there was a mixed payment reform in Quebec that paid all specialists that were working in a hospital a sort of base salary and then some top-up fee-for-service payments. And they did find that there was a reduction in utilization, but they also, and then they saw that physicians were spending less clinical time, which was sort of part of the goal because this model was similar to the academic salary models in Alberta, where they're like trying to compensate physicians who are teaching and doing research. So spending less clinical time was maybe an intended outcome, but they actually saw that they were spending less time in their office visits rather than in the hospital. So that the payment really wasn't applying to their office visits in the same way. So that wasn't necessarily an intended consequence. And then after the next, this estrogen study looked at the quality of care, and they actually increased length of stay in the hospital after this model. So moving into the United States, there was this obstetrician gynecology salary reform that happened in Michigan, and they switched from fee-for-service to a salary, and that resulted in a reduction in utilization of elective tubal ligations, but it did not affect office visits and did not affect all surgeries. total. Sticking with, at least there was one type of specialist that was the same. In 2 studies, we were focusing on OBGYN. So this perinatal episode, they were reformed in Arkansas, which was this bundle payment covered. A lot of bundle payments are more like at the organization level, but the way this one worked was it attributed all the costs for each obstetrics episode to the physician who's the one delivering the baby. So it combined, the episode payment was really a target budget essentially. So the physician was still paid fee for service across like all the care the patient received, but they knew that there was this target that they were supposed to meet. And if they met the cost target and they met some quality targets, then they got a bonus payment. So they didn't find any effect on utilization. They did find an improvement in one of the quality measures they looked at, which was the one that was really, people were doing really badly on before. So they started doing better on that one, but it didn't affect the ones where people were doing pretty well already. And then they did find that it reduced costs, but they ended up attributing that not to a reduction in C-sections, which was one of the goals, but to a reduction to a change in location of C-section delivery. So physicians were doing the procedure at a cheaper hospital rather than doing less of them. So there was also, I mentioned earlier, this ophthalmology capitation reform that happened in Missouri, where they switched from fee-for-service to capitation, and that resulted in reduced 2 per 1,000 Medicare beneficiaries, 2 less surgeries per 1,000 beneficiaries. So again, there's some significant but not necessarily meaningful outcome. And then the Medicare blended capitation reform that I mentioned, there were a number of studies that looked at this. It was focused on hemodialysis patients, and the goal, again, was to increase the number of visits they were having, outpatient visits they were having with their nephrologist. And then I think there were assumptions made that like increasing the number of visits would improve the quality of care people were receiving. So it did increase the number of visits, and there some quality improved, some didn't. There was a reduction in admissions and readmissions for adverse kidney outcomes. But there was also a reduction in use of peritoneal dialysis because this reform only targeted people on hemodialysis. So, and that was it was a small reduction, I think only about like 1%, but still, I think just keeping in mind, thinking about like how the models are designed and what the intended and unintended consequences are, what you might want to measure. So this study we know a lot more about because there were 4 studies. There were 4 studies of the same reform. Anyway, any questions on that?
One of the more powerful studies with regards to special solutions and the fee-for-service model was when Medicare decided to selectively reduce payment of certain fee codes for surgery. I can't remember exactly which one they were. They were electrical and the rates for those services. One, very significant difference in the number of services performed. Now that's complex. That's more complex than what you say in terms of why that might happen. There's extreme variation in care in the U.S. and then also variation in practice.
Yeah, for sure. Yeah, we didn't look at when a fee was only changed, like if the payment model itself stayed the same, but like the fee was reduced. That's not something we considered a different payment model, but it's definitely a change in how physicians are.
I'm not sure if you mentioned the change. Was there any change in fiscal sustainability metric, like for example, for capitation?
Yeah, that was not something.
There was not a change in the level of care provided, which would be good if the cost was.
Yeah, so only the episode payment reform in Arkansas actually measured costs. So that's another.
So it wasn't there.
No, so another sort of overall takeaway is we can't know, like we don't really know how these different models are affecting costs overall. And maybe people should include that as an outcome in their studies.
Well, it's hard to do multiple years, right?
Yeah. No, that's true. Yeah. Oh, Deborah?
Oh, yeah, so OBGYN, in the ophthalmology, perinatal emergency. I can imagine there might be some interesting issues by specialty that come into play as well.
Yeah, I don't think there were enough of each to notice a pattern between the different specialists, but I do think, well, there is a takeaway that I will get to in one slide. Just wait a second. But I do think that, yeah, there's so many different, I think a good point is there are so many different specialties, and they are just, they're delivering care in different places, they're delivering different types of care, the level of acuity of their patients are different, the issues of, do they even control who their patients are, like the anesthesiologist, are they getting to choose what they're doing, or are they just following what the OR, people in the OR are telling them to do, so can they even change their care? I think all of those things, like what the pattern of all of that to me is like, there's probably not one way to pay all specialists, and we need to think about where they're delivering care and who they're delivering it to and what they're delivering to design their payment model.
And did you deliberately not include, don't have it on this, primary care? Because that's a whole nother.
We only were focusing on specialists because all of the research and theory is about either all physicians or primary care only. So there was a systematic review of primary care done, but there hadn't been one of specialist care. So that's what we were focusing on. So I think I've kind of addressed some of these issues. Some of the challenges that we faced during this work was just like not just only creating a search strategy that found like the 4 seed articles we knew about versus finding 15,000 different titles was a challenge. We ended up going pretty broad, and a lot of people helped me do this systematic review. But then it ending up with only 11 studies on 7 different reforms, and was like, as I was just saying, like, what does this even mean? Can we come up with any takeaways or patterns that were asked? Was another challenge. And then, not to mention, like, despite trying to find rigorous study designs, they were still very low to moderate quality. And some of them that were technically time series analysis, like, didn't report like their methods at all. They didn't report like the number of physicians or patients, and like some of them didn't. Like it was really disappointing and confusing a lot of the time of like what was even going on for 2 studies in particular. So not all of them were bad quality. But anyway, so some key, like, what does all of this mean? And I commented on this along the way, but so we did see there were effects of these payment models, but as I tried to convey, like, if there even was an effect, it was very small. So, maybe payment model by itself isn't necessarily going to get the results that we want. We did see across these, it does seem that fee-for-service, as we would expect, is associated with higher utilization. And in terms of the EB study, there was like some evidence that there could be improvements in access under fee-for-service. And then we did see here that capitation and salary were associated with the decreased use of elective surgeries. But I think the results of the salary and the salary-based reforms didn't really fit what we would have assumed would have happened under a salary model. So they didn't reduce utilization of all types. They didn't reduce office visits. They didn't reduce all surgeries. They did reduce like elective surgeries, and they did reduce like office time, clinical office time, but not clinical time in the hospital. So to me, what like my main takeaway from all of this is that specialists are responding to incentives differently, varies in different settings and different procedures. So, okay, so the like main core of my my postdoc was looking at chronic disease patients like who were newly seeing specialists in Alberta, and comparing the care that they received between if they saw a salary physician or a fee-for-service physician. So we have had two publications from this work, one focusing just more descriptive, just focusing on patients with diabetes, and then another one looking at patients with diabetes and kidney disease. With much more complex methods, though it's still not fit into my systematic review criteria. So in both of these studies, our like general question was, is specialist physician payment associated with patient selection, visit frequency, quality of care, and cost of care for people with chronic disease? So we used ICD data repository from April 2011 to March 2015, including lab, administrative health data, registry information. And we created two cohorts, one of adults with diabetes who are newly seeing specialists, and another one of adults with diabetes and chronic kidney disease, or chronic kidney disease, or both, newly seeing specialists. So that meant that they hadn't seen a specialist for 4 years prior. And the specialists we considered were nephrologists, endocrinologists, and internal medicine physicians. And then for the first step was just like comparing the baseline characteristics of the patients, seeing the different types of physicians. And then we did see some differences. So we ended up doing propensity score matching to compare similar patients when we were assessing our outcomes. And then to obtain our outcomes, we used mixed effects modeling, including a random effect for physicians. Okay, so our main findings from all of this work were that we did see that patients managed by salaried physicians were sicker than those same fee-for-service physicians, based on having a higher proportion had advanced kidney disease. They were more likely to have more comorbidities, and then in one study they had a higher rate of admissions for ambulatory care sensitive conditions prior to seeing a specialist. So in the diabetes study, we saw that patients managed by salaried physicians were more likely to visit a specialist for appropriate indications, and we defined those based on lab data and medication use, just to sort of understand, is this person sick enough that they can't be managed in primary care anymore? So we also, we didn't find any statistical evidence of a difference in follow-up outpatient visit rates, quality and cost of care between patients seeing salaried and fee-for-service physicians. But we did find that the association of physician clustering with the outcomes was actually greater than the association payment model with the outcomes, which what that really just means is physicians individually are practicing so differently than each other. It's not necessarily the payment model, how they're being paid, that's driving how they're delivering care. There's other characteristics that are impacting that. So even though we didn't find a statistically relevant result, I did want to show you, let's see if I can use the pointer, that if, I know people online are looking at the top row of the overall rates. So the visit rate for follow-up visit rate for salaried physician was 1.75, and then for fee-for-service physicians was 1.54. So it was, the p-value was 0.06. We're so close. But so this is not, again, like the fact that salaried physicians were having a higher visit rate with these chronic disease patients, though it wasn't quite statistically significant, was again not something we would expect based on theory.
Was it adjusted for the fact that their patients were sicker?
Yeah, so I did, yes, so some of the key challenges of all of this work was that there were these baseline differences and the patients were sicker. So we did propensity score matching so that we only had patients that were similar to each other. So that in itself introduced a new challenge of different types of clustering. So we already knew that there were like the same patients were seeing like physician A, and there was a group of patients seeing physician B. So the patients seeing physician A are likely to be more similar to each other than the patients seeing physician B. So we had this patients clustering in physicians. The propensity score matching introduced like this clustering by matched pairs and then clustering by repeating patients. So the first time we did the matching, we allowed, like, so the idea was like each patient seeing a salaried physician, we'd find a fee-for-service patient that was close to them. So the first time we did it, we allowed the fee-for-service patients to be used more than one time. That introduced a whole other type of clustering. So we tried, sometimes not prompted by myself, but prompted by reviewers, to do different methods to address this clustering. And then I learned a lot in this process, and particularly that like a lot of research in this area actually hasn't addressed this type of clustering at all. And there's some interesting papers that talk about, if you're measuring quality of physicians, like this is really an important factor to take into account. But again, it's not addressed in a lot of quality and cost research. So people do, the most frequent way this is kind of clustering is addressed is through GEE modeling, where you're essentially saying like this clustering is happening, but it's something that's kind of happening by accident, and it's kind of a nuisance in a way. Like it's just something that's going on. Whereas like using a more hierarchical linear modeling, or like we use this random effect for physicians, and that is more like that kind of design is more saying this is something that's been happening systematically, and we want to include it as like a part of the analysis, not just something to like kind of control for. So we ended up using this mixed effect modeling, the random effect of physicians, to address that. And then it's when we use that type of approach that we saw that the salaried physicians had a higher visit rate. So there definitely is, I think my takeaway from all that is it is important to see how the physicians individually are behaving.
So I think it's important to acknowledge that in Alberta, the population of physicians who are paid by salary are pretty selective in the sense that they're clustered at university centers and tertiary care centers. So by nature, of course, they're going to have a higher volume of very medically paid patients with compared to their colleagues that are paid by service. So I don't know if that is important, but it's still important information.
Yeah, it's a good point. We did limit this analysis to only patients in Calgary and Edmonton, physicians in Calgary and Edmonton, to try to limit that bias.
Sure, yeah. I think that, but many of the physicians will be more clustered working at the tertiary care centers. Quaternary care centers are going to have, just because they're there, they're going to have a higher intensity. It's not going to select those patients.
Yeah, that's a good point. I mean, I think that gets back to like what control physicians, specialists have of selecting their patients at all. And yeah, not only are, they're getting referrals from primary care, they're getting just having to see the patients that come into the hospital. Yeah. Another challenge just thinking about study designs is like we don't have a variable that identifies a payment model until 2011, so I wasn't able to do like any type of pre-post analysis. Well, the variable doesn't consistently identify all types of specialists until 2011, so that was a limitation. So this is only, like, I do have the comparison group, but this is only a post analysis. Yeah, different.
Yeah, could I ask, because I agree with this, a little tricky with this clustering, I do think it's important, but unfortunately, probably lots of different models. Did you see a big difference? Like, did it really make a big difference when you did it one way versus another, controlling the different types of clustering?
Yeah.
It did.
Yeah, it switched the results, essentially. So before there were fee-for-service, when we did just a G, when we didn't do anything, or we used GE, the fee-for-service had a higher visit rate than salary model. It also wasn't statistically significant, but when we did the mixed effects modeling, we then saw the salary physicians had higher visit rates. So again, not statistically significant, but it did. And then we did look at sort of like, we looked at those, this isn't the supplemental materials for this paper, but we did look at once we adjusted, before we actually adjusted, because we were seeing this when we switched the results, we were like, what the heck is going on? So we wanted to try to understand. And then when I did look at the raw rates, like unadjusted rates, for all, like by different physician characteristics, we did see that there was a lot of variation. Like nephrologists tend to have higher visit rates than internal medicine physicians, for example, or like physicians who, I can't remember all the differences, but we were seeing in the crude rates these differences. So it did make sense, I think, that once we adjusted for these different physician characteristics, that we were seeing this different result. Okay, so just some like key takeaway points. Salaried specialists are, again, in this analysis, not seeming to appear to respond to incentives as theory would predict. They're taking higher sicker patients and having higher follow-up visit rate. But again, we didn't see like a statistical relationship between specialist payment and chronic disease care quality and costs. But then we did see this large variation in outcomes between physicians. So another stream of work that I've been involved in here is like not just patients who are new to seeing specialists, but when patients have been seeing specialists for a while and then need another level of care. So this is a paper I worked on with Braden and another postdoc physician, Aaron Trachtenberg, and we looked at the association of changing physician payment and the use of PD, peritoneal dialysis. So that's like that type of dialysis you do at home, rather than hemodialysis where you have to like go to a center and be hooked up to a machine. Anyway, so in this analysis plan, we did look at the changes in fee codes, but we also compared changes in PD rates between ARP and fee-for-service. So our main question was, are increases in the rate in the fee of peritoneal dialysis associated with greater use of peritoneal dialysis? So we used similar data, but we also supplemented that with a renal registry. So we found people who started chronic dialysis between 2011 and 2014. And then we made sure, as I mentioned, like we made sure these people were engaged with the specialist for at least 90 days before they started dialysis. And then so we compared the rate of PD use at 90 days after starting dialysis. So there could be some changes that happen once, like, so we thought that at that point you'd be like stabilized on your type of dialysis. And we compared the rates of PD for people seeing fee-for-service nephrologists and those seen by salaried nephrologists before and after 3 different fee changes. So previously you couldn't get paid for doing PD, so there was a change from $0 to $32 a week. Then the next change was from 40. There was an exclusion period because I'm just going to switch this slide. So this is a slightly blurry timeline, but yeah. So the first fee code change happened in the middle of study period 1, going from $0 to $32. Then we made this exclusion period for when the salary model was rolling out, thinking there's going to be other kinds of changes going on at that time. Then in study period 2, there was 2 different fee changes, going from $49 per week to $71 per week. And then in fee change 3, made it the payment for peritoneal dialysis and hemodialysis the same at $135.
Was there any secular trend in just the use of peritoneal dialysis as a modality, like in the literature, to say we should be doing
I think Brady can speak to that more. I mean, I think there's patients tend to prefer it,
right.
And it's a lot cheaper. And I know in Alberta there was efforts over this time to try to increase use of PD, like through education and outreach. Is there
That's where they include that salary group of docs who shouldn't have been affected by any financial incentives, and I think they'll probably show the time series.
I decided not to put it because it was so crazy after.
Yeah, that doesn't change much.
Yeah, so yeah, exactly. So the salary, these fees are only changing for the fee-for-service positions. The salary positions aren't getting any different money based on these fee code changes. So yeah, the salary was essentially acting as a control throughout the whole time period. So I skipped this though. We did a time series analysis that was like unadjusted, but then we also did differences analysis where we adjusted for patient differences. But yeah, the time series figure we had got really crazy in our last revision where we had like all the time periods together. So I just couldn't even figure out how to get it in, but yeah. So if I did show that, what we would see is it does look like there's a small increase over time in the use of PD, but none of it wasn't significantly different between the two groups. So yeah, we didn't see any difference like between salary and fee-for-service before or after these different time periods. And then we did do a sensitivity analysis where we looked at like the starting dialysis modality, like which dialysis modality you were on day 0. And when we looked at that, the fee change 3 was significant. So I'm not quite sure like what that maybe means in the long term, but I think it does seem to me to be pointing to when you got the payment more equal, like actually equal, that there was more of a change. But again, like just to point out, the payment for PD never was higher than the payment for hemodialysis. Yeah, and the time series also had no significant results. So a couple challenges of this study are just just the number of patients we had. We had over 4,000, but that in the hemodialysis blended capitation payment that I talked about, they had over 200,000 people, and they still didn't find it. Or they found like a 1% effect. So I think it's it's just like we might not have had enough patients to find a statistically significant effect. Another thing that we ended up not incorporating into this analysis, but just like when we're trying to understand nephrologists' incentives, the payments they're receiving is even more complicated than what we're presenting here. Like they actually are sharing payment for different patients. So it's just, there's this like just very complex incentives. And just my main point of even bringing that up is just like a payment model itself is not necessarily telling the whole story of like how the payment is designed, or there's other elements that are going into it, like beyond just if it's a fee or if it's a salary. So there wasn't any statistically significant results, and so we could think about other strategies to include in payment models. Another option would be we could try to pay more for PD, like actually have that code that be PD higher than hemodialysis and see if that would make a change. Okay, so just some brief look into what I have been working on after this the work I talked about today. So same with like theme of specialist physician payment, we're working on designing a study on how physician payment is associated with cardiac care delivery for Albertans with chronic disease. And in this study, we're not only interested in if physicians are paid fee for service or salary, but we're also interested if the physicians who are paid fee for service own a diagnostic testing facility or not. So like that's an additional incentive they have to maybe increase the use of diagnostic testing. We're working on designing this and like thinking a lot about what is appropriate or inappropriate use of diagnostic imaging. That's kind of interesting. Another study I've been working on is about the effects of clinical evidence and financial incentives on physician uncertainty when initiating dialysis. So after finding that like physician variation is a big impact, you know, we can think about maybe some of that variation is warranted, but maybe some of it is not warranted. Maybe standards, like coming up with ways to standardize practices of care could reduce that variation, which could then in turn improve quality. So, and when to initiate dialysis is a complicated decision to make. One of the indicators you would use is this eGFR rate, which tells you like how well your kidneys are functioning. So for the study, just this is preliminary analysis, but just a brief teaser. So I was doing a time series and a comparative time series analysis, looking at eGFR at dialysis start, and then looking at if there was a change after a randomized control trial that recommended starting at a lower dialysis at a lower eGFR, if that had an effect on eGFR dialysis start, and then some subsequent Canadian Nephrology Society guidelines. So there's been some studies on this across all of Canada that found that eGFR was actually increasing across Canada. The eGFR dialysis start was increasing across Canada before the RCT was published. So good news in Alberta, we have great nephrologists that don't do that. So we were decreasing over time. But then what I think this slide shows is there was this, like the slope. I realize that there's some level changes happening, and I'm just going to ignore those because I personally don't think they're relevant, and I'm working on how to decide, like do the analysis to not include the level changes. So I want to just focus on the slope changes, which is like thinking about the trend over time. So the slope is steeper after the guidelines are published than after the RCT is published. And my interpretation of that is that like there is a greater response to decreasing eGFR after the guidelines are published, which may in that and that's across all physicians. And then if we compare that to if we break up the physicians into salary or fee-for-service, we see it is also steeper for both fee-for-service and salary. And maybe fee-for-service, like in a sense, they would have less time theoretically than salaried physicians to be reading clinical, reading RCTs. So maybe the guidelines would be more useful for them to summarize all of the results. So maybe that's why we're seeing a greater response from fee-for-service physicians after the guidelines and RCT. So anyway, this analysis does include a physician random effect to try to address the physician clustering and is adjusted by patient characteristics. So I'm working on some other versions of this, and we'll see how much I can get done before I have a baby. And then it just some other, like as I've been talking about, like I think including some other types of elements into a payment model are probably important, including like quality indicators. So I've been working on some other projects looking at quality, focusing more on just the quality side. So with Reed, I've been working on this prescribing project, looking at if physicians are following prescribing guidelines and if they're also like what the cost differences are of the prescriptions that they're giving patients. So to think sort of about it. Well, yeah, anyway, I'm just gonna leave it at that. And then another project I'm working on is looking at quality indicators for atrial fibrillation and looking at if they change over time or if there are differences within Alberta for how different like healthcare zones are meeting these quality indicators. So we didn't need that much time for a discussion, but just some overall takeaway points. Just to sum up, our financial incentives do affect physicians' behavior, but payment reforms typically have small effects, and other specialist characteristics may actually be having a greater impact on how they practice. Specialists appear to respond to financial incentives differently than we would expect based on theory, and payment reforms in Alberta likely should consider additional elements, not like just a salary payment model or just fee-for-service payment model to drive improvements in healthcare. So I'll just stop there and have 2 minutes for some additional questions from the internet.
Are there any questions online? Maybe while we wait for them to type, you can see if there's any in the room.
Anyone?
The other thing that's hard to control for Amity is that you were just looking at outpatient care and the docs do a whole bunch of other things. So if all they did was outpatient care, then you clearly tease out the financial incentive of that payment for the outpatient care, but they might be trading off seeing outpatients against something that pays them more in a different situation, so it is complicated.
Yeah, that's true.
Are there also any differences in the model of care? How many nurses and other healthcare providers are working with fee-for-service and salary?
Yeah, that's a great question. Like in fee-for-service, my understanding is like they have to pay for their own people who are helping them, whereas salary, there's like an assigned person for that, right? Or like the physicians aren't paying for their assistants in the salary model. Is that right?
Varies across the 3 doctor groups you're talking about.
Okay. Yeah, so even like in the work we did that has the internal medicine, nephrologist and endocrinologist together, like, I don't think when we started that, we thought about like looking at them totally separately. Like we knew there were some differences, but like if I were doing it again, I would do like look at them totally separately. Because it just seems like my biggest takeaway from like the systematic review that was hard to synthesize is that they're so different, all the specialists are so different.
Thank you.
Thank you.